Good morning, everybody. This is a very tough act to follow, so I hope you'll indulge me. I want to thank Consuelo and Charles and Rhonda and my other colleagues on the planning committee for giving me the opportunity to tell some stories. And what I'd like to do this morning is tell two stories through their data, hence the title, Little Data, Big Data. And these stories are about the translational research partners across the spectrum. And I'm going to do it a little bit in reverse from conventional science, because typically we would talk about the methods and then the results. But this time, I think to tell this story, I'm going to talk about the results first, and then go back to some of the methods and try to glean some insights for what we can learn about translational research partnerships by looking at these two cases, a study in little data and a study in big data. And I want to acknowledge funding from NCATS, PCORI, the Sackler Foundation, and AHRQ all contributed to the data that I'm going to be sharing. So this translational research spectrum in a number of different manifestations should be pretty familiar to everybody, and it runs from T0 to T sub n, and every talk I go to adds another level of T, but for the purposes of this discussion, we'll at least end at T4 with translation to community with population level impact. And I was just really so impressed at the population level impact that you've described this morning, and hope that we can contribute to that as well. So to start with, I want to try to lay out how did we do this? And so we begin with two different infrastructures, a practice-based research network infrastructure, clinical directors network, and a CTSA infrastructure, the Rockefeller University Center for Clinical and Translational Science. And those two infrastructures have some common elements in them in terms of training, in terms of research, but they have some real differences in terms of the focus. And the work in the practice-based research network is really focused on clinical outcomes and comparative effectiveness research, and training investigators who are practicing clinicians, and with our engagement award, training patients to become investigators and colleagues in that process. Whereas in the academic center, the training is really focused on clinical scholars, on postdocs, on medical students, physician scientists. So while there's some overlap, the focus of training is somewhat different. But my colleague, Dr. Kost, has designed and described in her publication the community engaged research navigation process, which is really an open cycle that allows investigators and teams to join in the research enterprise at any one of these different stages and move into a collaboration that, in this instance, produces community engagement, community engaged research, and then comparative effectiveness research and patient-centered outcomes research. But I think one of the unique additions to the model that I'm going to discuss is actually embedding T0 or mechanistic questions within a framework of comparative effectiveness research and clinical outcomes study. So let me move into these two different case studies. And so the first is a study called the Patient-Centered Comparative Effectiveness Study of Home-Based Interventions to Prevent Community-Associated MRSA Infection Recurrence. It's a mouthful to say, so we call it CAMP, but it is really like CAMP. And those of you who were fortunate enough to have a CAMP experience probably have very fond memories. And I think that most of our participants would share the excitement of coming to our monthly CAMP meetings, which I'll discuss. And so we have a very wide range of stakeholders: patients, caregivers, family members of patients, community health workers, practicing clinicians, academic and laboratory investigators, statisticians, informaticians. And this is just one of the many group shots we've had the opportunity to take. And as you can see in this particular project, we have representation from several large public hospitals in New York City and several large federally qualified health centers, our colleagues at Rockefeller and at CDN, as well as a number of different academic stakeholders. But what came together in this project, which was initially supported through an administrative supplement from NCATS to develop a cohort study of patients who come into their primary care practice with skin and soft tissue infection. And we did that for about 2 years and learned a lot about it. But we had this one instant that I think really articulates the value of patient engagement. So at every one of our monthly meetings, and I'll go into what those agendas look like shortly, we have case presentations by a clinician. And in this instance, one of our most active clinicians was presenting a case that he had actually shared with us previously. And he shared with us at the moment that now she's very upset with him because she's had yet another recurrent infection despite incision and drainage, despite antibiotics. And she's really upset with him because she doesn't want this to come back. And then she said, and now her sister has it. Her sister was visiting and came down with the same infection. So that really galvanized the group to try to understand what are the predictors of recurrence. And we realized that that was probably the most important area of focus that we as a research team could address. So this question really derives from a single patient expressing her frustration with her care experience to a very concerned clinician who then shared that frustration that he experienced, that the patient experienced. And it generated this intense conversation where one of our laboratory investigators, Dr. Tomash, really was curious about how this phenotype comes about. Are there genetic markers? The clinicians were concerned about what the optimal treatment is to prevent recurrence. And when we looked at the data, we saw that this really was quite significant in the outcome study, the observational cohort. 40% of patients, in spite of most of them receiving CDC-defined treatment guidelines, following those guidelines, were developing recurrent infections if they had methicillin-resistant staph or methicillin-sensitive staph infection. So obviously this required our focus. And so we looked at the literature and identified a study conducted in the hospital intensive care unit setting that identified one strategy that was associated with significant reductions in an ICU setting of MRSA infection. So we asked the question, could we train a cohort of promotores to go provide home visits? And during those home visits, could they, in fact, train patients to implement the same protocol that worked so well in the ICU setting? And our control condition is usual care. So everybody in these participating sites across New York City and Westchester County, everybody received the CDC guidelines care. Everybody had a home visit where we conducted some surveillance measures that I'll mention in a moment. But the difference here was that the experimental group received materials related to decolonization, that is removing evidence of the bacteria from parts of the body that are not infected, and decontamination, removing the bacteria from surfaces in the household to reduce the overall risk of infection. And so we go into the households of patients, 278 are randomized in this PCORI-supported study, and we survey 13 surfaces that are high-touch areas, and we ask all of the household members if they would be willing to provide us with swabs of their nares, their axilla, and their groin, so that we can determine who in the household is colonized in addition to the patient. So that's our study. Now I'm going to tell the story through the results. So remembering that translational research spectrum, we have a colleague across the street at another CTA-funded institution, Weill Cornell, who's interested in sequencing and metagenomics. That's the slide up here to my right. And then to the left, we have our colleagues at Rockefeller who are interested in characterizing the molecular epidemiology of the specimens that have come through from these household studies. So this question began in the T0, T1 space with the investigator whom I mentioned before, Dr. Balachandra, who was interested in recurrent furunculosis, that is the skin and soft tissue infection that keeps coming back. We move into the T3 space to try to understand what are the clinical predictors that are responsible for this patient's experience. And this, in fact, is the patient who really generated the research question. And then to fast forward to where we are at the study that's currently underway, we have enrolled 135 of the 270, so we're at the halfway mark We are behind in our recruitment, but this is a challenging disorder to identify and recruit. But the key findings here are that 65% of patients in this study with a skin and soft tissue infection that has been diagnosed microbiologically to be caused by Staph aureus are also colonized in one or more locations. And 33% of the people that they share their home with are colonized. And perhaps most strikingly, 60% of the households are contaminated, have evidence of Staph aureus on the surfaces, the high-touch surfaces, most frequently on the kitchen floor, on the toilet seat, and on the bedroom floor. So maybe it is true you can catch this from the toilet. We don't know yet, but we'll know when we do the final analysis. But it is a reminder that this kind of infection really is a family affair. It is a household matter. It's not the problem of an individual patient, so it needs a solution and a strategy that addresses the entire household. So this takes us into the T3 and T4 space, and one of our investigators, who is a nurse in a health center in Harlem, when thinking through dissemination opportunities, introduced us to a barber who is a community leader on 125th Street, runs an event each year that was initially focused on HIV. But when we showed him pictures of MRSA, he said, well, I see these things on the scalp and the neck all the time. Are they contagious? So we realized in that brief conversation that was instigated by one of our nurse colleagues that we really do need to talk with people outside of the four walls of the healthcare delivery system. And we found, if you look at the Google Maps, around 3 of the health centers, those dots represent barbershops, beauty salons, nail salons. And these are just the ones that are listed in Google. If you walk around on the street, there are actually quite a number more. So clearly, these are important partners. And as we engaged with the barbers, and he introduced us to 55 barbershops that we had the opportunity to go into and provide essentially a CBE, continuing barber education course on infection prevention and control. And we found statistically significant increases at 1 month and 3 months in what people learned and what they retained and what they told us they planned to do in terms of preventing infection. So we found that this was an important partner and actually extended this work into the T4 space. And so the currency is always education. So while barber education is new to us, continuing medical education has been a major engagement currency that we've used across all of our research projects. And we feel that that's a very, very critical dissemination strategy. And I'll share with you a flyer where you can find all of those CME accredited projects. So that's the little data case. Let me take you now to the big data case, obesity, cardiometabolic risk, and adolescent pregnancy, building a de-identified electronic clinical database to examine biological and social determinants of nutritional status, pregnancy, and birth outcomes. So this project grew out of an NIMH-funded clinical trial that I ran a number of years ago with colleagues from another CTSA at Yale that randomized 14 hospitals and FQHCs in New York City to usual care prenatal care, which is individual care, or group prenatal care using a program called Centering. And while I won't go into that project in any detail, the intervention group, the group prenatal care, significantly reduced the incidence of preterm birth, low birth weight, and small for gestational age for these young mothers. But we also learned that the younger mothers who were in the intervention group gained less weight during pregnancy and returned to their pre-pregnancy weight a lot sooner than women in the control condition. And while nutrition wasn't the primary focus of this, it's clearly a critical issue. And in this collaboration with funding from the Sackler Foundation, we brought together another investigative team at Rockefeller with some members from the funder from CDRN, with some colleagues from another CTSA, Albert Einstein, and with the clinicians who were part of the first study. And this group of stakeholders includes OBGYNs, pediatricians, family medicine physicians, midwives, nurses, nutritionists, our laboratory investigators, IT analysts, statisticians, and our funders. And we're interested in building this de-identified multi-site EHR database to demonstrate the feasibility. The reason we started with this was that one feedback from the prior study was that they felt the research sometimes got in the way of patient care. And so we needed to find a more streamlined way of conducting research that didn't distract busy clinicians and teams from delivering care to their patients. And so we asked the question, could we leverage the resources of the electronic health records and limit our focus of attention to measures that are part of routine clinical care so that we didn't increase any of the burden of clinical research. So that's the current phase of the big data study that I'm going to describe. So we took the same population definition, young women aged 12 to 21 who received their care, and we were interested in looking at their electronic health records to characterize the care and the conditions that they experienced during the preconception, prenatal, postnatal, and early pediatric phases. We identified 85,000 records of eligible women from 7 of the 8 clinical sites that provided data so far. When we applied further restrictions and focused for this presentation on height, weight, and BMI, we are going to report on 55,000 of those women, hence the big data component. Again, this is the geographic distribution, and the Bronx is heavily represented in our population. This describes really 3 cohorts. So it's all women, the subgroup of women who become pregnant and those who don't become pregnant, and the babies of the women who are born in this interval. And we'll hope to have 5 years of follow-up for this cohort by the end of 2017. So we identified a long list of clinical variables of interest to the practicing clinicians and the investigators as part of this project. We divided those into 3 separate extractions and transmissions, and that was the site staff and the PBRN staff working together. And then we combined that with the expertise of the biostatisticians and bioinformaticians at Rockefeller, confirmed that the data were in fact de-identified, underwent cleaning, analysis, reporting, and I'm here to disseminate to you some of the results of our early cardiometabolic analysis. So this particular presentation, or this particular slide, categorizes women as underweight, normal weight, overweight, or obese, and then looks at their systolic and diastolic blood pressure at the first entry, the first visit during the cohort, the inception cohort. And what's striking here is that each systolic and diastolic blood pressure monotonically increase as you move from the underweight through the obese. The trends are very statistically significant, and yet the numbers suggest that we're still within or just within the range of normotensive, although one could predict that the incidence of hypertension will be faster and sooner among the obese and the overweight. And in fact, if we take the same breakdowns of underweight, normal, overweight, and obese, and we look at a definition of hypertension based on 3 measures from the chart at 3 different occasions, we find that the incidence, I should say the prevalence among overweight women was 11%, among obese was 19%, and those figures are 2 to 4 times higher than the prevalence of normal weight women. So we have and statistically significant. So we have a very disturbing picture here emerging of the life course and the cardiometabolic course. That picture is virtually identical if you look at the laboratory data from the electronic health record. So if you look at cholesterol, total cholesterol, you look at triglycerides, blood glucose, and hemoglobin A1C, because I compressed this into a single slide, the slopes of these lines don't really articulate the rapid rate of increase, and yet the trends are all highly statistically significant, and the pattern is virtually identical to what we saw for blood pressure and hypertension. I'll take this a step further, and if we look at the incidence of low birth weight, which you will recall was the focus of our intervention study, the incidence of low birth weight is inversely proportional to the weight of the mothers. And in fact, that's a similar finding to a large meta-analysis that included over 1 million young women published in 2010. So our two estimates of the relative risk are virtually identical. The confidence intervals are quite similar, and it's clear that birth weight is inversely associated with maternal weight. That may be related to a cycle of low birth weights, growth failure, low weight in teens, contributing to low weight in adults, and then repeating that cycle over and over again. Now, if we look at the other end of the spectrum, we also see that all of the large birth weight babies were born to the obese and overweight mothers. And so the cycle here of maternal overweight and obesity contributes to child overweight and obesity, in part due to dietary patterns, feeding environment, etc. But if we take this together, what we have here is a picture of an association that we can demonstrate now from the electronic health records extracted from routine clinical care. This is not a research setting. These are sites that deliver care, federally qualified health centers and community hospitals that really lead us to raising the question of these multi-generational effects. And I would speculate that unless we can bend the cardiometabolic curve and do it very soon, if we follow these babies for 20 years or so, we'll find the same association in the grandchildren that are going to be born to these babies in the next 2 decades, the association, the cardiometabolic associations and cardiometabolic risk. And if we could look back to the grandmothers, the mothers of the mothers we're studying, we'd probably see the same association. So we really have a lifespan model in place here of these multi-generational effects that remind us that we really aren't treating individual patients, we're treating families and communities and generations, and that this is absolutely essential work for us to try to intervene and intervene using the most effective methods and soon in order to avoid the continuation of these disparities. So I'll mention in terms of dissemination that we're in the relatively early phases of this project's dissemination, but I want to now reflect back on some of the principles that gave rise to these projects. So both of these studies have monthly team meetings. They tend to alternate between a longer face-to-face conference that's held at Rockefeller and conference calls. But what's been really critical has been the engagement of the clinicians and the patients in defining the measures and the study parameters, and in really understanding what kinds of questions can be structured from these observations. And so the title of this, Big Data, Little Data, we have in the MRSA study relatively few patients, under 300 in the current study, but quite a number of data points on those, as in contrast to the adolescent nutritional status study, where we have a tremendous number of participants, but relatively few measures. So this is an example of a meeting that the meeting template that we use for every meeting we have by phone or in person. And what's really critical is that everybody participates. And we ask the clinicians to provide a case report. We have one of our academic colleagues provide an update from generally a single publication from the literature. And we focus on opportunities for dissemination. And those opportunities can be conferences such as this, or it can be town halls and community health fairs in the neighborhood, and everything in between. We then have opportunities as we prepare for grant writing to break the large group into smaller teams, and this is an example of an approach that we followed in both of those studies, where we've essentially engaged a room such as this room in drafting paragraphs and narrative for grant proposals, where each group is broken up into a team that's assigned to them with a laboratory investigator, a health services researcher, a clinician, in the MRSA case, a patient. And these are examples of topics: patient engagement, patient recruitment, incorporating patient needs, defining patient outcomes. Each group then, there's a recorder, and the the text is presented and edited in real time. So we finish those meetings with very complete usable text for our grant proposals. And I mentioned before that dissemination is a really critical part of this, and I hope you'll have the opportunity to look at the cdnetwork.org Rockefeller webpage to see some of the programs in adolescent health that we've been presenting as part of this project. But to take it back, we've been able to try to incorporate something for everybody. So I think one of the key components of this model of embedding mechanistic questions in outcome studies is to ensure that there are variables and hypotheses that are related to each end of the translational spectrum, hence the partners along the translational research spectrum. And so we have several cases under development right now to extend and to hopefully replicate this approach. And to try to take this and summarize it, I'd say the critical issue here is you have to listen to each stakeholder's needs, priorities, their obligations, and understand their reward systems. We have to elicit and include the specific priorities for measurement and assessment and make sure that the outcomes are meaningful. We have to align those measures and priorities, but we have to be practical and pragmatic about this. So extensive questionnaires and burdensome surveys are just not going to be feasible in this kind of setting. But we need to be able to define the outcomes across the full spectrum, starting with the biological, moving into the clinical and patient-centered, and then into health services measures and public health measures. And so in this way, we're able to embed these biological measures within well-characterized clinical populations. But I think this is what the picture really looks like. And so as a reminder, when we're alone, we may be harmless, but get them together for a research grant and watch out. So thank you for the opportunity to drive and be a passenger.